Johnson es sumamente importante este evento.
Bueno, buenas noches a todos. Gracias por venir. Vamos a empezar esta actividad que son charlas en profundidad con un gran invitado acá de lujo que es Tommaso Parisi y que él tiene mucha experiencia en los temas que nos va a hablar, enfermedad perianal, enfermedad difficult to treat. Van a ver que hay varias revisiones y publicaciones hechas por él. Él tiene más de 200 publicaciones, digamos, en relación a temas de enfermedad inflamatoria, lo cual lo hace una persona con mucho desarrollo en la materia. Y para nosotros es una gran oportunidad volver a tener esta actividad en conjunto entre nosotros, los que estamos aquí presentes, pero también transmitirla, digamos, por YouTube, digamos, al resto de los hoy más de 320 socios que tiene Gadeco en Argentina. Lo creo que es un buen número. Así que no sé si quieres decir.
Va a haber un QR que se van a poner acá en las pantallas para que pueden escanear para hacer preguntas. Y la gente que está conectada por YouTube también le va a aparecer un QR para escanear, y cualquier pregunta que quieran hacer después de cada una de las charlas va a haber un breve momento para armar un debate.
La idea es a que sea una charla, después discutamos preguntas. Si después queda alguna de esas y ya empezó la otra, la podemos hacer al final. Bien amena, bien, digamos, entrado en lo que es la parte práctica o en lo que ustedes crean conveniente. Y la idea es que aprendamos un poco todo esto nuevo que viene en las nuevas definiciones y el nuevo manejo de las enfermedades más complejas que tenemos dentro de la enfermedad inflamatoria intestinal. Así que bueno, Tommaso, un gusto que venga acá. Hemos estado hablando un poco de él, de su actividad. Ha hecho parte de su actividad, la hace en Italia, en Milán, en San Rafaelo, y también ha estado en Cleveland. Ha vuelto a Cleveland hace 2 meses y está ahí al medio camino, digamos, de seguir haciendo actividades en Cleveland. Y la verdad que es un gusto tenerte aquí. Él va a dar las charlas en inglés, pero va a responder las preguntas en castellano, y las preguntas las podemos hacer en castellano perfectamente. Habla muy bien castellano, pero digamos, es para que todo el mundo pueda preguntar sin problema. No hace falta que sean las preguntas en inglés. Él la entiende bien y las va a responder en castellano igualmente, ¿saben? Esa aclaración creo que vale, ¿no?
Pues
bueno, Tommaso,
muchas gracias. Y buenas tardes. Es un verdadero placer estar aquí hoy con vosotros y gracias por invitarme. Gracias a Johnson & Johnson, a Gadeco y a todos vosotros. Mi español se ha perdido en los años, así que, como os decía, mejor que no torture el idioma y hable en inglés para todos. Pero, por supuesto, si queréis preguntar en español, si os entiendo, contesto. Entonces, lo primero de que hablamos es difficult to treat. Perdón, me quito del medio. Esos son conflictos de interés. So, what is refractory IBD? it's something that we think we know. Everybody has an idea, but the definition is actually pretty hard to give. And up until 2021, there was nothing, zero, absolutely nothing. So in fact, ECHO proposed the first and only definition of refractoriness back in 2021 with a topical paper saying that basically we should call refractory a disease that has failed all available options, and in case of Crohn's, that is also not amenable for surgery. And this is very strict, it's very definitive, and it changes over time because we know that new medications come in the market not every year, but every couple of years or so. And the other problem is that if you use this definition, definitions are useful if you can make research on it and if you can divert energy. Otherwise, they're just publications that stay there. So the problem with this is that if you have such a group of patients, which luckily are not that many, it's very hard to think about trials, clinical trials for these patients. So we thought back in 2021 that there was room for improving this because failure to anti-TNF was no longer the only logical way to classify patients because there were at that point already several other mechanisms of action, and the increase in treatment was bound to continue in years, and we wanted something that was intermediate, not super strict, but also allowing research to be made on that. So we looked around and we found out that rheumatoid arthritis and rheumatologists had already thought about it and came up with their definition, which is nothing novel. We keep on copying from rheumatology since many years. We are just a few years behind. They copy from hematology, but we copy from them. And other conditions like hypertension also have their way to classify patients who are somehow complicated to manage. So we ran a survey which was actually very much participated here in Latin America, and Brazil and Argentina were among the top countries that responded. So maybe some of you guys were around at the time and remembered the survey. And we asked physicians treating IBD what is complicated for them, what makes it hard to manage, what is the problems, what do you think is the limitation on the management. And we gather all the information, then we ran a consensus, and we came up with this definition, which was that we should call difficult to treat a disease that has failed at least 2 classes of advanced medications with different mechanism of action, or in the case of Crohn's disease, a disease that is still active despite 2 surgeries. So the idea being that if you already exhausted 2 strong options like surgery or biologics, then you're running out of options. You don't really know what to do. But it's not so extreme that you cannot think about a trial for this kind of patients. Plus, on top of this, we added a few other subgroups like pouchitis, again, very much neglected from clinical trials, and complex perianal disease, which again, it's neglected from clinical trials. We'll talk about it in a second. So fast forward a few years, and then we started looking, and some of you guys did the same, how many of our patients fit in this group, so meet at least one of these criteria. And what you can see is that surprisingly, in very different contexts around the world, we have very similar prevalence of patients which have at least one criteria for difficult to treat. And it's around, let's say, between 20 and 25% of patients on biologics. So a subgroup of patients, of course, but pretty consistent. So enough to think of a group of patients for which is worth designing clinical trials, for example, or doing basic science investigation to understand what makes this disease so much different from anything else. So the interesting question, of course, is not just how many are there, who are they, but also what kind of evidence do we have today to guide us in treatment. So what do you do basically if a patient has failed 2 classes of advanced medications, which could be anti-TNF and vedolizumab, for example, which are obviously very little high quality evidence for this, because patients who fail multiple classes of biologics or who have been operated many times are excluded systematically from clinical trials. So it's hard to make the calculations because most trials don't even give you the number of patients which failed 2 classes. Now they are starting to do it. We published this, but up until like 2024, it was almost impossible to derive those numbers. So this estimate of 3% is to be taken a little bit cautiously, but you can see that the percentage is small. However you look at it, it's small. And most trials, even the ones that do include these patients, don't report efficacy results for this subgroup. So you have the result of your new drug. They give you maybe the break even now between bio-naive and TNF exposed, which is already something, but they don't tell you how it performs in patients who have failed like 2-3 classes of medication. So we basically don't have high quality data. We need to rely on case series, real world evidence, which is of course good but less accurate, and you don't have hard endpoints. You usually typically don't have endoscopy for that kind of studies because patients don't do endoscopy as they should be doing. So this is one part of the glass, the half empty part of the glass. The other side is that things are indeed improving, and if you look at how many patients exposed to biologics we're starting to include in clinical trials, this is obviously increasing, especially in Crohn's disease. You can see that now we have quite a few trials. Sorry, you cannot read the names. This is the name of the trials, but quite a few trials that have 100% of population bioexposed by now, which is good. But it's one by. So things are moving ahead. So what can we do? If we don't have high quality data, we need to rely on what we have. And the first thing we did was to look for associations. So we took the patients that difficult to treat, in this case Crohn's disease, which is a little bit more interesting than UC, I would say, and we found out and we looked at what was associated with it. And not surprisingly, you see the obvious things. So behavior like stricturing or penetrating disease or perianal disease, that's well expected. But the one thing I want to shed some light on, and I think it's going to be one of the key points in this conversation, and as well as tomorrow, one of the many presentations of tomorrow, is time to treatment. So this is the only variable that you as a clinician can change, can affect. Everything else is on Mother Nature. So time to treatment, which we define as the time from the diagnosis to the start of the therapy. We divided it in 3 years, but that's arbitrary. You see is statistically associated with the future, the likelihood of then becoming difficult to treat. And this is important because it's consistent, and I'll show you, in a lot of literature. In other way, we should pay attention on the diagnostic delay and the treatment delay, because this might impact what happens next. And in fact, I want to just give you this used to be a slide with a clinical case. The clinical case is so trivial, it's so common that this one is probably better. Thanks. So the clinical case is so trivial that I just moved it into basic concepts. So think about the story of a patient. In this case, was a young man who starts developing symptoms which are compatible with an IBD. Goes to his family doctor. Should I take off this one? ¿Lo quito? Okay. Que se va al médico de cabecera. Eso va a ser complicado. Lo tengo aquí. Okay, so the story is a very trivial one, but the point is not in the complex case, but it's what can we learn from this? And I'm sure, I guarantee 100% of you guys have seen a patient like this. So the patient is a young man. He goes to his family doctor. He says that he has abdominal pain, a little bit of diarrhea, and of course it was a stressful time, like all the time. And the family doctor thinks he has IBS, gives him some probiotics. He feels a little bit better, and some time goes by. So until the symptoms come back, this time they're worse. And so it gets a calprotectin and then a colonoscopy and a diagnosis of ileal Crohn's disease in this case. A few aphthous ulcers in the ileum, nothing terrible, but a diagnosis. Okay, now there is a second step. It goes to a gastroenterologist. The gastroenterologist, perhaps in this case, was not an expert in IBD and thinks, well, you have a little bit of aphthous ulcers in the ileum. You're feeling okay. It's nothing terrible. He gets a one course of steroids and then he's put on maintenance 5-SA, mesalazine. And then time goes by, and there is no plan. That's the other key point. So mesalazine, and then we'll see again if symptoms come back. Just come back to the clinic. Until time goes by, in fact, and a fistula, a perianal fistula appears with an abscess, and then the first gastroenterologist, who's not actually an expert in IBD, refers him to an IBD expert, who finally takes a decision and starts infliximab. But importantly, and this is the other key point, infliximab monotherapy. So no azathioprine, no immunomodulator combined. And again, same problem, starts the treatment and there is no plan for a reassessment in a given time. And so what happens is that the patient after a while loses response, feels better initially with infliximab, but then loses response and I work in a big center, so we get a lot of referral from other people, especially from the south of Italy, and then I see him, and then what do? You have potentially failed the best or one of the best drugs that we have, especially from the context, and we need to decide. So this is immediately, it's not technically a difficult to treat patient yet, but it's already a problematic patient because we don't have that many options for perianal disease, or at least we don't have that many data for that. And the point of this is not what to do next. Also, in this case, we start to reset, but what could have we done better? And I kind of mentioned it along the way. The first one is obviously the diagnostic delay, which was pretty much avoidable. But again, oftentimes it's not in our hands because it's the family doctor or the patient, so there is little we can do. The second point is that we keep on seeing a lot of mesalazine in Crohn's disease. And the guidelines are extremely clear. It's ECHO and AGA, every guideline you see, they advise strongly against the use of mesalazine in Crohn's disease. Yes, we keep on giving it because we don't want to take a decision. It's a safe thing. It's nothing bad is going to happen. You know it. And the patient has his placebo, so he goes home with a placebo. You know it. He or she doesn't, and you buy time. That time that you think you're buying, you're actually subtracting it from the chances of getting a better response to your patient. The second problem is that starting a medication means you should start a plan. You should have an idea of what you are expecting from this medication, so you should have an idea of when or how to reassess the disease. I would advise colonoscopy is probably the best way, but if you don't have it, at least a calprotectin is better than nothing. And again, oftentimes we keep on seeing a lot of symptom-based management, and we know that we cannot trust symptoms any longer because symptoms are not accurate and can be very misleading, and especially they come after the problem. So, and the third problem that in this case was the monotherapy. Again, by not giving 6 or 12 months of azathioprine, you're subtracting, you're taking away from the patient a very important drug because you're running more chances of losing response to anti-drug antibodies. And I bet that a lot of people will answer that azathioprine is not the safest drug we have, so we don't really like to use it. And I agree on that, but on 6 months or 12 months, azathioprine is absolutely safe. There is no risk of lymphoma for a short-term duration. Instead, your benefits in terms of what you can achieve more from your drug are consistent. So all of this is to say that many times we are the ones creating the complication by not using at the best our options. And in fact, the time that goes from the diagnosis, first of all, to whatever outcome is consistently associated with worse things. So if you look at it, diagnostic delay is associated with need of surgery in Crohn's, which is a clear sign that things are going to go bad, are going to go south. Mucosal healing, again, with a strong meta-analysis, all the studies on the same side of the bar. It's pretty consistent that every time you look at it, you see that the earlier the disease, the higher the rates of mucosal healing, or the opposite, the longer the disease, the less the mucosal healing. And if you look at clinical trials, these are different clinical trials of different drugs in Crohn's disease. You see, I hope you can see, but the red line is a slope down, showing you that the more the time goes, so the x-axis is time, the less is the percentage of response decreases. That's irrespective of the drug, so it's across the board for all of them. And if you look at, these are very recent studies. One is profile study, which was meant for other things. The other one is the Love CD study. But you see that if you start, in this case, was infliximab plus azathioprine within 2 weeks from diagnosis, which is very, very difficult and it's complicated to do, but you achieve staggering results. With 79% is something that we never see in clinical trials. Yeah, the bar is always like, if you're lucky, you see the 50%, if you're very lucky. And again, even vedolizumab, which in ileal disease is considered, with good reasons, to be probably not the best drug, you still achieve a lot of remission more when you use it early on in the course of disease. So I hope I'm convincing you that time is really relevant, especially for Crohn's disease. If we look at colitis, the association is somewhat less clear. So I think we can discuss. This is going to be a very nice point of discussion, but it's not clear that the delay in treatment will affect the outcomes. Again, this is the same meta-analysis, but with UC trials. So the line here is pretty flat. I'm sorry for the quality, but I mean, the red line, it kind of explains itself by itself. So there is no clear trend in loss of response. And in our data, the difficult to treat cohort from Milan, we didn't see a strong association. But what you do see is a greater risk of surgery. Now, surgery in UC comprises multiple reasons, but obviously dysplasia is one of this. So it's reasonable to say that perhaps a longer wait between the moment the patient needs a therapy and the moment he actually gets him will impact perhaps not the response to the therapy, but the overall burden of inflammation that he went through, and therefore his risk of surgery. And then it came out, this Portuguese study a couple of months ago, like let's say in June, I think it was out, that seems to suggest that, again, a longer wait, even in colitis, is associated, at least in their cohort, with the progression of the disease or the dysplasia, which I can easily believe, and structural damages, which again I can believe. There are patients with colitis that develop strictures or even just a thickening of the bowel wall, which then affects the way the bowel moves. So again, there are reasons to think that it's a good idea to start aggressively also for colitis. After starting, then you need to have a plan to detect what is happening, if it's a primary or a secondary failure, because from that depends your ability to use what's left of the drug class. So in this case, we're talking obviously of anti-TNFs. So if the patient lost response over time, then you might still have a room for treatment optimization or therapeutic drug monitoring. And I know this is not common for you. It's not common for me either. But there are some settings in which it might be actually useful. But the practical thing is that you cannot distinguish primary from secondary unless you have objective measures of disease. Because if you don't plan a colonoscopy, if you don't plan a calprotectin, then there is no way you're going to know if your patient actually improved in the meantime or was simply feeling a little bit better and now relapsed, or simply just did bad all throughout. So, and to exemplify this, this is one of the largest cohorts available today, and it's the UK one. And so the curves might not look spectacular, but they are very powerful in terms of numbers. And if it's not surprising, but if you look at patients who had a primary non-response to a TNF, which is the one on the left, if you use a second anti-TNF, the red line here, then you have a big delta compared to the non-anti-TNF. So in another way, if you fail anti-TNF, if I give you again anti-TNF, primary failure I'm talking, then chances of responding are pretty slim. Instead, if the failure was not a primary failure, so if you lost response, there might still be a room for using the same class. This is extremely important because if you have few options, because reimbursement, because of the way the market works, then you don't want to waste adalimumab after you use the infliximab, or the opposite. It's a precious resource and you want to keep it. So moving on, what to do about the third line, a fourth line, and so on and so forth. The truth is there are so few studies, and that it's hard to draw conclusions. And the problem is that the few studies we have, they become immediately old by the time they are out, because the options we have keep on expanding. So now we're starting to see the data with ustekinumab, and it's already kind of outdated because now we have all the IL-23s coming out, and in fact, some studies on risankizumab, I'll show you, are already out, and in a couple of years' time, we're going to have plenty of data on guselkumab. It's simply a matter of time. And the other problem is that this kind of studies lack hard measures, hard outcomes, so we never know endoscopy. So clinical remission, I advise you to keep in serious consideration a study that only reports symptoms, because a patient that has a long history of disease underreports his symptoms. And this is something we see all the time. If you do clinical trials, I'm sure you get a lot of screening failures for patients not meeting the requirement of symptoms, not because they're not doing bad, simply because they underreport, because they are so used to being bad that they feel it's like their new normal. So they underreport things. So this is something we should keep in mind when looking at the evidence. What we can kind of, at this point, gather is that probably vedolizumab is not a great drug when used later on in the history of the disease. And so this on the side is a very recent study, also from Milan, looking at vedo, uste, or JAK inhibitors in colitis. On the other side, kind of a smaller study in Crohn's, testing the two combination of whether using vedo or uste when an anti-TNF and the other one were failed. And what you can see across the board, so the JAK inhibitors are the blue line and the uste is the green line, they come up pretty higher up than vedo, whether you look at steroid-free clinical remission or biochemical steroid-free clinical remission, which is arguably a little bit more objective. And again, like the yellow bars, which is vedo used at the very end, not as great as the other ones. Moving on, more evidence. This is a meta-analysis. I'm not a big fan of meta-analysis, so I only show them when I think it's really relevant, but I think it gives us a hint of one way of looking at the problem. So this is the typical meta-analysis of drug efficacy from clinical trials on prior exposure to anti-TNF in ulcerative colitis. So what you see here on the side are groups of classes of medications. And what you notice is that while in naive patients, they all perform pretty well, and you can discuss about the numbers, but they all do very well. When you look at anti-TNF failed patients, so exposed patients, then the odds ratio become kind of weird. You have that lymphocyte trafficking inhibitors, so vedolizumab for the most part, and sphingosine 1-phosphate modulators, do a lot worse, so less likely to achieve remission, while JAK inhibitors potentiate and IL-12 or IL-23 specifics stay the same. So this is indirect evidence, of course, and we need to take it with a pinch of salt and a little bit of criticism, but this could guide us in the way of thinking of how to use the available options, at least in colitis. So if it was for me, and this is personal opinion, and we can discuss about it, because I know that vedolizumab is actually a very good drug when you use it first line, and I know that it's not going to be as good when you use it later on, then maybe I want to try giving it first attempt, if that's available, if that's possible. We're lucky we can give it, but because I'm going to use all of the efficacy of the drug. And second, I'm going to
leave for the JAK inhibitors for the end. Now we can discuss where to position IL-23 because they perform so well across the board, whether you use them at the beginning or at the end, that they are kind of the jolly, like the kind of card that you can always play. Now I'm going to move up because time is running out. There are no obvious clear differences when you look at the fourth, fifth, sixth line. This is our data from Milan, but it's very, very hard. So we're never going to get good answers about this. The best hope we have is to get clinical trials designed for multi-refractory or difficult to treat patients. But a trend at least can be seen, and is that IL-23 specifics and upadacitinib perform very well, or at least acceptably well, in refractory patients where you would not expect good results. So this, for example, is a small cohort, but very refractory, with anti-TNF, Vido, and ustekinumab used, so including ustekinumab. And risankizumab, in this case, achieved decent clinical response rates, actually pretty good. Again, I advise to be cautious on symptoms in this kind of patients. And the same study, the data from the ANEIDA cohorts of Spain, again showing that both RISA and UPA were doing pretty well in third line after 1 year. More of this kind of data. Again, just to say that there is hope in the sense that there is a proportion of patients who failed 2 or 3 classes which can still be recovered with these new medications, but the unmet need is still pretty high. This is data from the Netherlands, published, I think, 1 week ago, achieving 51% of corticosteroid-free remission at 6 months in difficult to treat Crohn's. That's remarkable. And then I want to give you a little hint about what we could do in the future, because the drug options are there. We know them all, and it's pretty much end of it. What if we were to start combining diet, at least in Crohn's, where we have the strongest evidence? There are some retrospective positive, at least in the short term. We'll see on the long term. And I think the most interesting part is that, I don't know if you can read, but anti-drug antibodies development seem to be very much decreased when you add partial enteral nutrition, so modulan. So again, this could be another way to boost the efficacy of drugs that we have already, to try not to get at the end of the line where we cannot do much more. So to wrap up and conclude, think ahead, try to avoid delays. That is perhaps the most important and most actionable thing you can do tomorrow in your clinic. Most of the evidence is now on IL-23 selective and upadacitinib. That doesn't necessarily mean they're the best. It's simply that they get used later, but it's still convincing evidence. So there is at least room for optimism. And clinical remission can be, in the best cases, achieved in somewhere around 40%, but probably when you look at harder data, I forgot to mention it, it was 20% in one of the studies that I showed you. So limited, but optimistic. And with this, thank you very much, and happy to take any questions.
Tomaso, ¿qué valor le das a la optimización? Porque en general en todos los tratamientos avanzados suele ser off-label
Sí.
la optimización. ¿Es lo mismo para cualquier tratamiento avanzado? ¿O cuánto tiempo le das para chequear los resultados?
Okay, so I'll distinguish between, there are drugs for which there is very little evidence that optimization works. For example, vedolizumab, we used to do optimization, but at this point it's probably waste of time. So we optimize, at least I optimize my practice IV infusion, and I consider that a little bit of an optimization. I do not shorten the interval of ustekinumab more than 8 weeks. 8 weeks, but I never use the 12 weeks interval. And what we do instead use a lot is the extended induction for mirikizumab, which I know you don't have, but has 3 IV infusion at the beginning, and we kind of give 3 more and that can be done. It's on the label if we are not convinced. So not all drugs work the same. Looking at JAK inhibitors, tofacitinib a lot. For example, tofacitinib basically the 5 milligram is it's a dream. You never manage to maintain a patient. A patient so severe to require a JAK inhibitor most likely will need a high dose, at least for tofacitinib. We don't do that much with UPA. We're kind of happy with the 30 milligram stable maintenance. And Filgo, we use less and less, but we don't optimize. So this regarding which drugs. Now the when. So depending a little bit on when you expect to see the results. In a naive patient, where let's say a clinical trial setting, the ideal setting where you have all the information from clinical practice, from clinical trials, I set the time of the first visit around 3 months after the induction. And by then, I always want a calprotectin. So I want to see a trend in the calprotectin. And I'm lucky enough that I can do also bowel ultrasound. I don't do endoscopy so close because the patient doesn't like it. And we have waiting lists anyway, so it would be complicated. But if I have symptoms, calprotectin and bowel ultrasound, then I'm kind of happy to take decisions based on that. So around 3 months, I decide whether it's worth optimizing early. Then there is a second step time point around 6 or 9 months, a little bit depending on how severe the patient, when I decide whether the drug has failed or not, and I can give it a little more kick. So for example, in the case of adalimumab or infliximab, oftentimes I find myself optimizing around the 6th month because the patient was doing better, but at 3 months, I still don't know really if it's enough better or simply a little bit better, and I push it until the 6 months. So for the majority, I would say, which the majority of patients I see are not bio-naive anymore. I don't see bio-naive patients since a long time, probably. I tend to decide optimization around the 6 months.
Ok. Gracias.
Gracias. A ver, acá hay una pregunta. Es muy interesante, digamos, los efectos adversos en los pacientes difficult to treat son mayores que los pacientes que no han alcanzado este objetivo, pacientes no difficult to treat. ¿Cómo qué
Sí,
esperas?
salió el paper de mi amiga y compañera Virginia Solitano hace un par de semanas en JCC, en Journal of Bronchiolitis. Y sí, los pacientes con several previous failed medications, they do have more safety problems. And this is something we should take in consideration when designing clinical trials, because in the clinical trials, you don't want to see any adverse events. If there are adverse events, then the sponsor doesn't want to run the trial because they are worried that their drug will look bad. So we need to think ahead that a patient that has multiple problems is somehow more likely to have, bad things tend to go together, right? So yes, it's something to keep in mind, and yes, there is a trend.
Y una pregunta que está acá, no sé si alguien más de acá de la sala quiere hacer una pregunta. Allá, Astrid.
Aquí, gracias. Cuando empezaste a hablar de lo que dificulta tratar a un paciente, empezaste justamente marcando la tardanza en hacer el diagnóstico y poner un tratamiento efectivo. Y usaste un ejemplo que es quizás uno de los más difíciles, que es la ileitis aislada en alguien que tiene síntomas leves. Y es muy difícil, y quiero saber cuál es tu opinión en cuándo decidir ponerle un anti-TNF, por ejemplo, o algún tratamiento de avanzada, como solicita el profile, que ellos hablan más que nada sobre el paciente moderado a severo, es más fácil tomar esa decisión. Pero en el leve, que no es mesalazina, por supuesto, el tratamiento, pero ¿qué tratamiento tiene lugar la satioprina todavía? ¿Qué tiempo le das para esperar que un corticoide haga efecto? ¿Y qué tratamiento le darías en ese paciente que es tan leve que no te querés pasar con un biológico, pero no es lo suficientemente severo?
Absolutely. I think this is a key question. It comes up every time and everybody has his own opinion. I'll give you mine. So first of all, I think that the share of patients with Crohn's disease that do not deserve a biologic, it's much smaller than the one that we actually have. So if I have to make a mistake, I'll definitely do over-treatment. Am I doing something wrong? Okay. No, I think creo que vaya. Okay. So if I have to make a mistake, it's going to be over treatment 100%, because the treatments that we have now are super safe. super safe. If you look at IL-23, the safety tables are so boring that you don't even go to the bottom. There is absolutely no signal whatsoever. So the moment you have access to medication so good, if you were the patient, you would rather have an injection every 2 months than running the risk of being the one that finds out later that they were supposed to be overtreated. But there are some patients in which you only see a few, like 2 aphthous ulcers, and in that case, it's kind of hard. So I think that is this very narrow setting where you can consider azathioprine. I use azathioprine monotherapy in those patients in combination with it's not indicated for induction. Of course, it takes a long time to work. So that is one of the cases in which I give budesonide plus azathioprine, and then I rescope the patient, and I want to see again a colonoscopy at 6, maximum 9 months. And whenever I do this kind of approach, I talk to the patient, I tell them, like, look, the chances that we're going to need to escalate the therapy are more than the chances that you can be well just by luck of having a few aphthous ulcers. But so we don't want to run the risk of missing out. So what I don't want to do is forgetting about the patient. So I make sure that he has the colonoscopy booked instead of just, oh, we'll see, we'll find out, go back to your family doctor, and then it gets lost. And then I already do the talking about we might need a biologic, we'll see if you're lucky or not. And of course, any other risk factor. So if he smokes, I start banging on smoking. Smoke is a big problem for us. We have 20% of smokers. And if there is family history or any other risk factor, then I kind of go on the treatment side.
¿Qué opinas de utilizar combinación de tratamientos en alguna etapa en pacientes, por ejemplo, que han fallado 2 líneas ya, y tal vez la tercera línea, en vez de hacer una sola droga, combinar?
Absolutamente, sí, lo hablamos en la tercera de las presentaciones. It's obviously the future. It's going there. We have a little bit of problem in access of combinations, so we have to find ways around to get approval for it. But I'll show you also our data is not new anymore. It's from 2024, so things have changed a little bit. But we in the difficult to treat patients, we have quite a few combinations. Now the question, and we're going to try to answer that as well in the third talk, not answer, but at least give you an idea where we're going, is which combination, because I know that that's going to be the next question.
Sí.
There are some very few hints of what could be logical, but well, no spoiler, otherwise you're going to sleep later. O sea, siempre en IV.
Persistentemente con tratamiento endovenoso.
Eso no tengo experiencia yo, pero sí que hacemos mucho del repower, el ensayo donde le ponía otra infusión, como de otra inducción. Eso sí, yo diría que mi pequeña experiencia sí funciona bastante. Pero de seguir con endovena, no. Y además tendríamos un problema de reimbursements.
Hay una pregunta ya al fondo, sí. En castellano, si quieres.
No problem in English.
No, para.
May you permit me? Hi, Thomas. Good night.
Hi.
It's very nice to see you again. First of all, congratulations. Is that working? Okay. Well, I had 2 questions, but the second one was performed by Professor. So, according to your lecture, I don't know if you have any personal opinion regarding the role of historical assessment in the definition of patients. According to your lecture,
So I know where the question coming from because you worked with Marietta and I worked with Marietta too, and so So I think that the role of histology is more on the other side of the spectrum. So on when we are trying to decide whether the patient is really in remission or not. So in the context of big problems where everything is on fire, I think that there is no role for biopsy and looking for neutrophils. If the patient has ulcers, I don't even look at the only reason why I need the biopsy is to rule out CMV and dysplasia, of course. But other than that, I'm going to take my decisions on the endoscopy. So I think that histology it's interesting for sure, and it's potentially even useful, but on the other side of the spectrum. So a patient, for example, that is being I know this question will come out at a certain point in the evening because the typical question is, can you discontinue treatment at a certain point? So if the patient is on has been on biologics for many years and is well, can you discontinue? That may be the setting where histology can help you decide whether the answer is yes or no. I would go for answer no, but I accept the idea that there could be somebody. So if this answers your question.
Vamos a la última pregunta. Gustavo.
Una pregunta. Respecto a enfermedad inflamatoria difícil de tratar, sacando la enfermedad de Crohn perianal y teniendo en cuenta los fenotipos de las otras enfermedades inflamatorias, ¿no? Y el peso que tiene la demora en los tratamientos. En tu experiencia, ¿qué crees más importante? ¿Los fenotipos de las enfermedades o la demora en los tratamientos? Que en algunas cuestiones hacemos nosotros difíciles de tratar, llegamos tarde al diagnóstico o al tratamiento.
So, te contesto con los únicos datos que conozco, que son los míos, en that graph that I showed with the multivariable logistic regression, that's multivariable. So every factor that you see on the left is accounted for all the other ones. So in that one, the delay was more or less as big, if not even bigger, than the impact of the phenotypes. So it's one study, one cohort, might well be wrong. There are many biases of all possible things. But in that context, at least in Crohn's disease, the delay was even more impactful than the phenotype. So it's something to think about it, because you can change the delay. You cannot change the phenotype.
Bueno, pasamos ya a la siguiente charla.
Sí.
Si quedan algunas preguntas, las podemos hacer al final a todas.
Okay, so, well, if you're in the room, you obviously know about perianal disease. I don't need to tell you that it affects some 20% of patients. And one thing that we kind of forget sometimes, it can be the first manifestation of a Crohn's disease. And this is something that we should remember to our colleagues, maybe surgeons, that sometimes see fistulas and think about that could be a Crohn's disease. We'll go back to that in a while. And can be also the only manifestation of Crohn's disease. And that's another narrow area where it's not really clear what we should be doing. And it's obviously a severe phenotype that it's problematic for the patient, for us that we don't know what to do, and for the payers as well. So the first point is, what makes perianal disease Crohn's compared to a non-Crohn's, so a cryptoglandular fistula or an idiopathic fistula. So in idiopathic perianal fistulas, the index insult, so the first, the primum movens in Latin, the first thing that moves in the whole process is an infection of the gland, which the infection then needs to drain somewhere else. In Crohn's disease, instead, what we see is inflammation, and a type of inflammation which is erosive. Now, I want to leave you with a little bit of a philosophical question, of which I don't know the answer, but is that you can think about Crohn's disease as something that can swing to a more a greater deposition of collagen and matrix, and therefore you get strictures, and in that case you have matrix metalloproteinases, so the enzyme doing too little work, or it can swing on the opposite side with the enzymes doing too much work and eroding and creating the channel. So it's, in a sense, fascinating, the idea that you have obviously a problem with the stroma, that they can swing the two ways. I don't know why, so and I think nobody does. But it's also seen, going back to Crohn's disease, perianal Crohn's disease is seen in about 12% of patients which don't know that they have Crohn's yet, meaning that the channel, the fistula, the erosion starts, the sinus starts before the infection, the abscess, and all the rest. So this is something to take into consideration. And the asymptomatic sinuses are independently associated within the development of the fistulas. So now the pathogenesis, it's not clear for sure, but we have a few points. First of all, if you look at the genetic association among Crohn's disease, among the many types, perianal Crohn's disease has its own specific association. So again, a little bit of another philosophical question is perhaps, are we calling Crohn's disease, and I think the answer is yes, what are instead many diseases, many different diseases, some perianal, some other intestinal, and some comprising the both. So this, at least from a genetic point of view, this is, it's probably at least supported by the data. The other point is, well, the pressure, and there is a matter of pressures, and the fact that the internal opening happens in a high pressure zone. This is particularly consistent and not seen in cryptoglandular inflammation. Moving on, yeah, well, this we already mentioned. If you look at the pathways involved, again, I don't know if you can see well, but if you cannot read, this is perianal Crohn's disease, of course, and the first gene, the one that is most significantly increased, and we're talking about logarithms, so many times, is an MMP, so matrix metalloproteinase 13 in this case, which is it's a group family of metalloproteinases. So it's, again, the one most activated is the one degrading the matrix, digging the hole in the tissue. Instead, in cryptoglandular fistulas, you don't see MMPs. You'll have to trust me on this because you probably cannot read. So this is important. So there is a genetic difference between the two, and this is well expected, but it kind of hints in the direction that we think we know. On the other side, there are differences in gene expression in the area of the fistula and the rectal area, even when this rectal area is inflamed. So Crohn's disease rectum is CDR, and the Crohn's disease fistula is CDF. So there is a lot of differences in the two. Again, suggesting the idea that the fistula is in a sense a disease by itself. It's separated from the rest, at least from a genetic point of view. Now, moving on, again, this is the same. One of the highest impact, one of the most expressed areas is interferon gamma response and interferon alpha. And these two are hallmarks of type 1 immunity diseases, which is in the old days the classification that Crohn's disease used to get. Now, things have changed because of the IL-23, which is a little bit complicating matters, but again, suggesting that it's a highly inflammatory and a highly autoimmune condition rather than infectious. Again, to differentiate it from the idiopathic perianal fistulas. And again, you can see this in immunohistochemistry, and I'm not going to bore you with all the details, but just to stress the fact that it's two different things, although they present in similar ways. Now, from a clinical point of view, it's been an absolute dead silent field for many years. So since 1999, when Present published the infliximab induction trial in the New England Journal of Medicine, there has been very little trials conducted in this, which makes our life harder because we don't really know what other options we can use and how effective they are, and it's hard to get high quality data. As a matter of fact, you see there was the induction trial, then the Accent 2, which is the maintenance trial, again infliximab, tacrolimus, which didn't work, the Vastrogel, which is the stem cells, which which I'll let you decide if it worked or not. Filgotinib, which kind of worked in perianal but didn't work in Crohn's overall, so would never continued. And now, as of this morning, we have the data of from the GTED, the French IBD study group. And I believe in a few weeks or perhaps months, by the end of the year, we should have Fusion, which is guselkumab data. So two extremely interesting pathways, molecules, and very promising data I'll show you in a second. So going back from the beginning, and this is also anticipating another question, this is the original, I hope you can see it's a little bit blurred, but infliximab 5 and 10 milligrams compared to placebo was providing benefit by means of 50% or greater reduction of number of opening fistula. And this is the seminal trial in 1999 that moved everything else. I want to stress again the fact that it's 5 and 10, and the 5 is higher than the 10, because this goes against some other data that we'll see in a second. And I'm sure that this is an excellent topic for the discussion, whether should be using higher doses in patients with perianal disease or shorter accelerated induction regimens. Now, moving on, this is the Accent 2, so 5 years later, the maintenance trial, saying that basically you could maintain remission in about 36% of the patients. You can see it on the bottom right for you. Again, this is well-established data. Then, what is the role of drug levels? Because the original trial was suggesting that they were similar, and if anything, the numerical benefit was for the 5 milligrams, so the low dose. But then there came out other studies. This one is much more recent from Andrés Yarur, which is Chilean, by the way, showing that infliximab levels were correlating with the healing, so suggesting that perhaps we should be using higher doses. And he was not the only one to observe this, because tissue levels, so measured in the tissue and in the blood, for both infliximab and adalimumab, kind of correlate. Again, you'll have to trust me on this, but it's the blue boxes, the red boxes are negative correlation of the levels with the symptoms. So symptoms, PDAI, with the levels. So basically saying that the more levels of drug you have, whether this is in the fistula or in the serum, the less symptoms you have. And again, top class improvement, we'll talk about top class improvement, but it's basically the new classification of perianal disease. So the progression, let's say the worsening of the disease, again, was correlating or was associated with lower levels. So two pieces of evidence, and as of now, the guidelines are not clear on whether we should be using higher doses or not, and I'll ask you what you guys do. I personally, except for strange cases, tend to stick with the regular 5 milligrams. But what about other drugs? Because infliximab and adalimumab are 2, but we know that unfortunately chances of not being well with these 2 are pretty high. So we had, until this morning, only retrospective post-hoc analysis about ustekinumab in the CERTiFy and IM Unity trials. And there is this meta-analysis. Again, I don't like meta-analysis, especially when it's only 3 studies, but suggesting that there could be an advantage over placebo, and a fairly big one, actually, if you look at the numbers, because 58%, but with a 26% on placebo. Now, there is a problem that this kind of trials here were not designed to capture the progression of the fistula. So you need to think about that. Symptoms it's a little bit of an old way of measuring a fistula. Nowadays, you would want radiology. So this data are kind of outdated. But now, as of, again, this morning, the French study on ustekinumab came out, and it's a strange study that has a lot of, I can tell you a few stories about it, but it's very promising in terms of results, but very small in terms of numbers. And they had to cut it short at the end because they could not enroll. And the reason why they could not enroll was that placebo is obviously not an appealing option for somebody with perianal disease. None of us would like to get placebo in the trial. So that was one of the obstacles, and so the enrollment was going so slow that they decided to cut it short and present the data. However, the data is pretty promising. And if you look at the circled one is in anti-TNF refractory. Again, I don't know if you can read. So you see that the blue bar is in the range of 60%, which is, again, particularly high if you think about the setting. And the other key point to highlight is that this study, as well as the fusion study, which I'll show you in a second, use the combined endpoint, which is clinical and radiological. And that makes much more sense because it gives us an idea that not only the patient is symptom-free, this was the primary endpoint was remission, but also free from collections, so no abscesses or forming new abscesses. And so then you have to rely on retrospective data like everything else. And there is this fairly large multi-center propensity score matched, which means balanced for potential confounding factors. Study that shows that in perianal fistulizing disease, after anti-TNF failure, USTE was potentially working better than VEDO or a second anti-TNF. So again, suggesting the idea that the IL-12/23, and we now know that it's only the 23, the one that actually works, is a good option. And again, as a third-line agent, 78% of USTE-treated patients achieved response, which again, encouraging if you think about third-line in perianal disease, but retrospective. So the fusion study that I mentioned before is a study about guselkumab, which is, I think, one of the reasons we should be more excited to be in the field of IBD now, because not only it's a selective IL-23 inhibitor, it's also potentially a different and we think more effective one. And it's the only one so far that has been prospectively and randomizedly tested in the perianal setting. So a very high quality type of trial, high quality of data that will inform us, and the moment we're going to have the full results might change the paradigm, the dogma that was infliximab first, and then you think about the rest. So the results were again also this one, as I mentioned before, had a combined remission of the fistula and radiology at 24 weeks as a primary endpoint, and then all the secondary endpoints that you would expect. Some results were already presented at DDW in the same session as the ustekinumab results. And if you were not there, I'm just showing again the numbers. Again, you need to think about that this is fistula remission, so very strict. And you also have to consider that the placebo rates in the French study were a lot higher. So the delta is what actually makes a difference. So this tells us that in about 1/4 to 30% of patients, we can achieve remission at 6 months with guselkumab. Of course, if you lower the bar of your endpoint, you get higher results. And this is fistula response, so no remission response. And you get like in the range of 32 and 35. Again, interesting, especially if you're new to guselkumab. There are 2 formulations for the maintenance. So the 100 milligrams every 8 weeks and the 200 every 4. So it's a pretty wide range in terms of concentrations. And if you look at all the data that is being published so far, so the clinical trials, because there is basically no real world data yet, you would expect that the higher dose is the one performing better, but we don't actually see any difference. So another question that I'm sure is going to come out in the discussion is, when and how do you choose which kind of maintenance regimen? But I'll leave the question for later, otherwise we don't have anything to talk. Upadacitinib, also a potential option. Some retrospective data, this is again post-hoc analysis of the clinical trials, and again in the range of the 20% when you look at 52 weeks, so a little longer time point, and resolution of drainage. So again, not the same endpoint, so not easy to compare, and no radiological outcomes. So there is actually an ongoing, it's about to start an ongoing prospective upadacitinib trial. So we're gonna know something about UPA in perianal in, let's say, 3-4 years time. Now, this is one of those settings where things can go so complicated that you might need to resort to different options like combination therapy. There is no real results about this because it's only 33 patients with different combinations, so I'm not showing you the precise numbers, but this is something to think about. And I can tell you that the majority of the combinations were an anti-TNF and ustekinumab, which again makes sense for what we know about Crohn's disease and the potential role of IL-23 in mediating the immune escape from anti-TNF. Now, practical tips for the real life out there. So first of all, this is the top class classification published a few years ago. It's a lot of wording just to say that we're moving from an anatomy-based classification to a strategy-based one. And the key of the graph is in the class 2, which is where you should take a decision whether this patient needs a medication, a surgery, and particularly a defunctioning surgery. This is sadly an option and something that we probably should be considering a little bit more or a little bit earlier in the history of perianal disease, just to mention this. And then the other point is that perianal disease of Crohn's can present isolated. So although it's statistically speaking way less common than cryptoglandular or idiopathic fistulas, we should not forget it. And I know that if you do IBD, you know it, but we're not the only ones seeing fistulas. The surgeons see a lot of fistulas, and they sometimes forget. So the idea here is that if there are many more horses than zebras, but zebras do exist. And again, it's one of those settings where you might be causing a huge delay in the management, and so the chances of getting a good success. And the obvious risk factors for Crohn's disease compared to a cryptoglandular fistula are obviously the granulomas, the presentation, and the abdominal symptoms. In those cases, if you think you have an isolated perianal disease, it makes perfect sense to treat with whatever drug you have available, so an anti-TNF potentially, even though if the patient doesn't have any luminal manifestation of disease. I firmly believe, again, that that's one of those settings where even in the doubt, if you treat a cryptoglandular fistula with infliximab, it's not a huge deal, rather than if you miss Crohn's disease and you're not given any medication. And this is what we just said. And again, that can be the first manifestation of Crohn's. So again, isolated. And talking about numbers, if you look at this, this slide is going to show again. If you look at one of the largest meta-analyses available with more than 100,000 patients, the diagnostic delay in Crohn's disease is significantly longer than colitis, and it spans in the range of 8 months, which might not sound terrible, but if you look at the distribution, the interquartile range, you see that there is at least 1/4 of patients that have to wait more than 15 months. So this is one of the settings where you should really act fast, going back to what we were saying before. So here, I don't know if you can read, but this is what we were mentioning, I was mentioning before, that there is a very nice consensus paper on the fact that there is plenty of reasons to treat isolated perianal Crohn's disease with biologics, even though you don't have ulcers in the ileum or in the colon, to justify a full-blown, typical textbook Crohn's disease appearance. And there was a consensus made, and the percentages in responses on the support of anti-TNF therapy are overwhelming. So it's A+, for example, this A+ is strongly agree, A is agree. So 100% of them always agree. There is absolutely nobody that thinks that an isolated Crohn's disease to the perianum doesn't deserve treatment. And this was the last slide. So thank you very much, and happy to take any questions.
¿Alguna pregunta de la...?
Astrid, ¿hay una pregunta?
Sí. Sin micro.
Gracias por la charla. Te pregunto por el Fusion que dijiste, alguien lo va a preguntar. Voy a la inducción del Fusion para cerrar fístulas, empiezan con la dosis máxima y después el mantenimiento pusieron las dos opciones. Y las dos opciones, tanto la mínima como la máxima, fueron muy similares, aunque la mínima incluso fue hasta superior por un puntito. Mi lectura fue distinta, mi lectura no fue, o lo que yo me pregunté no fue cuál elijo. Para mí es sencillo, elijo la más barata, porque necesito pagarlo. Mi lectura fue, si no funciona con la dosis más baja, no tiene sentido que intente optimizar. Quiero saber qué pensás de eso.
I'm not aware of any data answering this, so it's my personal opinion based on using guselkumab now for about almost 1 year, and the other IL-23s. There is a small range where you can capture again a response by increasing doses or shortening interval. So I believe that it's worth trying if the situation, if you think the patient had a good response but not enough, so you see it's working, but you're not fully satisfied, I think it's worth giving it a try. Again, with a time frame. So you need to set a time like 6 months or whatever, and I want to see some improvement. Maybe 9 months or a little longer. But it's opinion. It's not based on data.
Gracias. Hola, ¿qué tal, Analía? Creo que soy la única cirujana. Voy a defender un poco el gremio. Claramente un coloproctólogo que entienda de enfermedad inflamatoria sabe la diferencia entre un origen criptoglandular y un paciente con enfermedad de Crohn perianal. Mi pregunta es porque muchas veces nos van a necesitar para colocar los sedales justamente para poder hacer el tratamiento, sobre todo cuando el paciente tiene compromiso del recto. Ahora, en los casos en que el paciente ya tiene manejo de ese recto, en donde histológicamente está curado o macroscópicamente lo vemos bien, tenemos opciones quirúrgicas y mi pregunta era si ustedes las consideran como la de hacer un colgajo o una fistulotomía, hablando de fístulas bastante simples, no obviamente fístulas complejas, en un paciente en donde el recto ya respondió al tratamiento y está sin actividad.
So you're asking if the rectum is responding to medical treatment and there is a perianal disease, whether I should involve the surgeon in the management. Is that the question?
Sí.
Okay. See, the short answer is yes. I would involve the surgeon every time, and I let the surgeon decide if they think, because I think, first of all, I'm not a surgeon. Second, they tend to know when it's not the case of touching it. But I think that no perianal disease should be managed just by the gastroenterologist. At least the gastroenterologist doesn't know. Not a surgeon. If it's a surgeon managing the Crohn's, maybe he has all the competences to do it by itself. So I involve the surgeon. We have an MDT meeting, so it's me sitting with the surgeon and I let them decide. But the PISA study shows that when you do the two things, when you combine medical and surgical, you tend to have the best approaches. And as a matter of fact, I forgot to mention that all these studies allowed cetones to be placed if judged by the treating physician, the treating clinician. So that was always, it's never mandatory. It's always like case by case, depending on the anatomy and on the. Sí.
¿Qué experiencia tenés vos de funcionalizando pacientes? ¿Cómo les va a esos pacientes después de que se desfuncionalizan? ¿Cuántos terminan en prototomía de todas formas?
Muchos. La verdad que muchos. Lo siento.
Nos están pidiendo, por favor, hacer las preguntas por el QR,
QR.
porque estamos con temita con el micrófono.
Yo tengo una pregunta. Desde esta perspectiva, digamos que la enfermedad de Crohn puede debutar como una fístula aislada, digamos, y sin afectación luminal en todo el tracto intestinal. ¿Cuán frecuente ves esa situación? ¿O cuán frecuente han empezado a buscarla, digamos, ¿no?
So the best data, it says 8.2%. Then if you look at the literature, there is a little bit of movement. So I think there is probably a lot of patient underdiagnosed, because in my personal opinion, I don't see 8% of isolated Crohn's disease, isolated perianal Crohn's disease. But if you look at the numbers in the literature, that's the range. I would say more towards the 5%. But I do think I do see patients, and what I see pretty consistently is that these patients, if you look closely enough, then they are typically not so isolated. They tend to have a few aphthous ulcers in the ileum, which maybe what were overlooked at the colonoscopy, or a calprotectin that is always borderline, and something is not quite fitting, usually, at least in my experience.
Pero probablemente juegue un poco la evolución de la enfermedad. Tal vez ese paciente estuvo 2 años con una fístula y nadie lo pensó.
Absolutely.
Tomaso, con todos nuestros pacientes con enfermedad fistulizante, con fístulas perianales, ¿el objetivo debería ser el mismo? Es decir, clínica, o tenemos que esperar a que se cierre la fístula o a que no tenga colecciones?
No, obviously you need to be realistic, and you cannot hope that everybody's going to be healed. And in fact, the top class classification, which I think it's a little bit complicated to read through, but the key point of that graph with the circle is that basically you have a key point in where the patient has the fistula, perianal disease, and has symptoms. So if it doesn't have symptoms, it's fine. You can do whatever you want. You decide, but the situation is quiet. In the class 2, which is where the symptoms are, then there are 4 subcategories, and those 4 subcategories depend on what you and the patient think are the realistic goals. So the type 1, of course, is the one that you see responding to the medication, where you think it's reasonable to expect a full healing. But for example, already in type 2B is where you are happy with just controlling symptoms, and you accept the idea that the fistula will never heal, or at least not in the foreseeable future. And then there is also the 2C, 2B3. So where the fistula is not only not responding to therapy, but is progressing, and there is where you should start thinking about the functioning, and if anything, even protectomy in the following ones. So yeah, it's you need to realistically, we are not able to cure everybody, not even half of these patients.
Creo que no tenemos más preguntas en el chat. Si nos pasamos a la próxima charla.
Okay.
Gracias. Si quieres un poquito de agua.
Okay, so this one is supposed to be a little more exciting, because we're looking about the future. So it's less about the hardcore data and the numbers, which at this time of the evening it's really tough, especially for me. I have a lot of jet lag, but trying to think about where things might evolve and what we could be seeing in the next, let's say, 15 years, 20 years from now. I'm an optimistic, so I think that most of the things that I'll show you now will actually end up working and being in practice. So again, this have not changed since the first slide. Okay, so we all know about the unmet needs. There is a lot of patients that still don't do well despite the medications that we have available, difficult to treat, high burden, high risk of patients, and so on and so forth. So where is the field of medical research going? I would say in 3 different directions, which are not completely different. They have similarities, but we'll see them together. The first one is novel medications. So if you pause for a second, if you think about that, developing a molecule from a preclinical to phase 3 and commercial phase costs in the range of hundreds of millions. You must be thinking that the fact that there are so many molecules and so many companies investing that amount of money, it means that they think that their products are good enough. So I think it's very reassuring seeing this slide here, which is not intended to be read, but it's the list of phase 2 and phase 3 trials ongoing as of last year for colitis on the left and Crohn's on the right. So I think it's, at least it's a very good news, because if they're trying, if they're putting their money on this, it means that there is hope that this actually works. Second point is that we're getting, I mean, the new molecules, the new drugs are coming. You can see a few trends about it. One is that they tend to be more practical. So we're valuing more practicality and seeing less and less infusions, so less and less burden for the patient having to travel, for you to find a time slot and the chair, and you need the nurse. The nurse is never available, and so on and so forth. Oral administration is the new big thing. The second thing is that we're accepting less and less safety concerns. So if you think about it, probably you don't use here much sphingosine 1-phosphate modulators, but I'm sure you've heard about how bad of a commercial, an advertisement they got just for the fact that you need to do an AKG to the patient before starting etrasimod, which is otherwise a super safe drug. It's like a new mesalazine. But just for the fact that it could, in theory, cause bradycardia, which is something that we were not used to see, the field kind of paralyzed just because we're talking about a new potential, very small, very rare safety event. So this, on one side, is perhaps a little bit silly because we're risking not using all the medications that we have available, but on the other side, certainly reassuring because we are setting the bar higher and higher. And perhaps an anti-TNF nowadays, if we were to develop it now, would look so much more unsafe compared to an IL-23 selective inhibitor that we would be saying like, oh, well, this, I'm going to leave it for only like desperate cases. So first, so practicality, greater safety, and there are new mechanisms, which is the exciting part. And there are many of this. The one that you obviously heard of is obefazimod, which is a microRNA stimulator. So a completely different class of drug, completely different mechanism of action. And a little bit like JAK inhibitors, it's working much more downstream, so potentially targeting multiple pathways at the same time. Now, this doesn't necessarily mean that it's going to be more effective, but the fact that there is a new mechanism of action is so interesting because it means that new ones will come. Like if you think about it, we started with TOFA, and now we have Filgo, UPA, and so on and so forth. We started with Riza, and now we have 3-IL-23, and getting better and better at that every time. So I think there is a lot of room for optimism in this. And the other ones are, sorry, I forgot to mention, the other ones I think it's very nice to keep in mind is TL1A. TL1A it's like a big brother of TNF with probably less safety signals. We're still too early to say. And potentially, and this is the big bet, which nobody knows yet, possibly anti-fibrotic effects, and which would make a big difference because it would change completely the management of Crohn's, even though we don't really have any human proof of efficacy. The third one is phosphodiesterase 4 inhibitors, so apremilast, which are comprimidos, tablets, that are widely used in psoriasis. They were tested in colitis years ago, and they did work, but they were discontinued for commercial reasons, and now they're coming back with more specific and selective mechanism. So these three are just the ones that I want to mention. Of course, the list is long, but we'll go to the even more exciting things. So combined approaches are becoming more and more mainstay. Now, this is not science fiction anymore. We have clinical trials published, the VEGA study, which was combining guselkumab and golimumab, and sets a little bit the proof of concept for then the DUET CD and the DUET UC studies, which are ongoing, but with promising results presented at DDW. So the idea of using at the same time multiple combinations. And this is interesting because it's one of those settings. If you know the story of combination therapies, the first trial was published in 2007 and was infliximab with natalizumab. Now, 2007, it's a long time ago, and the results were not bad. Nothing wrong happened. It's true, natalizumab never made it, never became interesting, but the whole field froze not because of efficacy, but because we were looking at rheumatoid arthritis. So if you look at the trials in rheumatoid arthritis, they tried a lot of combinations. They are typically ahead of the game. And in rheumatoid arthritis and in systemic lupus, it doesn't work. It doesn't add any benefit. So we saw that and we stopped saying like, okay, if it's not working in RA, why bother testing in IBD? And now we're seeing something completely different, that instead in IBD, at least, I mean, this is very limited data, there are benefits, and most importantly, the balance in safety and adverse events doesn't seem to switch to tilt on the other side. So this is something that differentiates our field from what we usually look at as our older brothers, or where to take inspiration. And as I was mentioning this before, this is our cohort in Milan 2 years ago at this point. And I don't know if you can read, and the boxes moved all over, but there is a lot of long names, which are combinations, and these are absolute numbers. We're talking only about difficult to treat patients, but we are effectively using some combination in some patients, of course, selected ones, of course, with a lot of problems with access to medications. And just to challenge a little bit the idea of adding too many drugs cannot be done because it's too much of a hazard, there is this very nice, the Explorer study run by Jean-Fred Colombel, which used 3 drugs for induction using methotrexate, adalimumab, and vedolizumab for like a heavy dose, heavy load induction, with the idea of treating early and hard, hitting hard, and then getting better results. It's a single arm, so we don't really have a comparison. They try to do Bayesian or statistical comparisons, but I'm not going to get into that because I don't really trust it. Now, the other key point is, because we have at this point many drugs, how do you combine them? So there is very little evidence so far, and the only piece of evidence which everything revolves around that is this beautiful study from Erlangen in Germany, where they showed that at least in Crohn's disease, the non-responders to anti-TNF, so the red dots, have more expression of genes associated with IL-23. One is the receptor, the IL-23 receptor. The other one is the P19, which is one of the 2 components of the molecule itself. And so this was supporting the idea, and this happens only after the treatment. I'll show you, if tomorrow you're at the Immuno Summit, I'll go a little bit more in the details of this study because I think it's beautiful. So this one came out in 2018, 2019, and kind of justified the idea that IL-23 was a good match with anti-TNF, and potentially also after, not potentially also, and after anti-TNF because of this. And so following this came the VEGA study, which was a proof of concept study, relatively small numbers, but still convincingly enough showing that combining guselkumab with golimumab in ulcerative colitis, you could get better results than either one alone. And this is interesting because nobody thinks golimumab is a great drug, but guselkumab obviously is. So if you can get more than a good drug, then it's worth paying attention at least. So moving ahead, these are ongoing combination trials. Ongoing combination trials. There is a mistake. The last one is not ongoing anymore. It's the But you can see there is obviously a lot of interest, and you can see also that there is a lot of this revolves around the association of an anti-TNF and an IL-23, or in some cases ustekinumab, so 12-23. Then the question is, okay, but how are you going to compare them? Because they're coming all from different studies. And there is one company, Aspire, that is actually running parallel arms of different combinations. Of course, they cannot do all of them, but you see that they have in pipeline the alpha-4 beta-7, the TL1A, the IL-23, and then the combination of this. So one day when this study, it's called Elevate UC, is going to be over, we're going to have a very good data set to understand which combinations are more relevant to one another. Moving ahead, even more forward, we're probably going to use on one side combination of the old medications that we know, and on the other side we're going to have new drugs which combine in the same product two medication exist. And this is for commercial reasons as well, because if you're using two drugs that already exist, then the patent will expire eventually. But if you can combine them in the same one, you have obviously more practicality, easier way of administration, less troublesome regimens, and a new molecule itself. So the Sorriso trial, which was published earlier this year, is a phase 1b, so we should not really take much consideration of the results. But the idea is that, again, these are the placebo bars, and there's a decrease in symptoms. The two doses of the combined product, which is oral, IL-23 and TNF inhibitor, work better than placebo. So I would just stop for that at the moment without commenting, because it's small numbers and the dose is still to be found. Then many more bispecific antibodies are coming to the market, and potentially there are no reasons why not trispecific. In fact, there are a couple of companies working on trispecifics. A lot of this work around, again, TL1A and IL-23, because those two seem to be a good match, just like anti-TNF and IL-23. Then again, this I mentioned it before. It's a sort of combination as well. These studies were done in exclusive use of diet and parenteral nutrition, but there is no reason why we should not be combining parenteral nutrition with medication. And as a matter of fact, with adalimumab, the preliminary data shown at ECHO this year are very encouraging, at least in terms of protection from antibodies and drug immunicity. We're going to let you know about our study in possibly a couple of years. We're 1/4 of the way of the enrollment. Now, moving to the final and by far most exciting part of the presentation, it's cell therapies. So cell therapies are been around for a long time, and the idea was that you could reset the immune system rather than just switching it off. We are grown up to assume that after the cessation of inflammation, for example, you take a patient, you treat him with a biologic, the fact that the inflammation is no longer there means automatically that everything went back to normal. If that was the case, by stopping the medication, then you could have sustained remission. But instead, we know that if we stop the medication, the majority of patients will relapse. So it means that even when there is no inflammation visible and you cannot detect any sign of disease being present, there must be something somewhere in the patient that determines the relapse. So it's this idea that's been around for a long time, and in fact, in 2017, you probably remember the ASTIC trial, which was a trial of hematopoietic stem cell transplant, which surprisingly worked very, very well. Although it's a small number of patients, these were patients extremely refractory that had failed almost everything, and they had 93.75%, it's only like 17 patients, endoscopic response, which is staggering. It's completely out of any other scale. And even if you look at the endoscopic healing, so the remission, the bar stands at somewhere in the 80%. In the 80% range, which is incredibly good. The problem with this was the safety. There were one death, and the setting requires hospitalization, requires heavy chemotherapy with problems with fertility, so not good for a young woman, of course. And in the end, most patients were relapsing. So despite the excitement for the idea, the process never took off and kind of hit the dead spot. But if you look at what happens in these patients, you see that the hematopoietic stem cell transplant reshapes a lot of the myeloid lineage, but not as much of the lymphoid lineage, especially in the B cells. So the before and after, they kind of look relatively the same. And so the idea is that while there is a complete remodeling of one side of the immune system, there is not much or not sufficient changes in the other one. Now, this is not the best proof, but the other graphs were too busy and it's late in the evening. And the other point is that there are persistence of memory cells populations, both in the marrow and in the tissue. So B cells, now here we get to the story, have been the Cinderella, the Cenicienta of IBD for a long time, because we've been thinking that the disease is modulated by T cells, the ones producing all the cytokines that we inhibit, the ones that we block by trafficking, and so on and so forth, and B cells were bystanders. But if you look closer, there are good reasons to believe that B cells have a role as well. So at least in ulcerative colitis, it's less clear for Crohn's disease. I agree on that. But in the 1950s, we found that there were antibodies against colonic epithelial and goblet cells in patients with UC. Then you all know about the Pianca association, which is pretty consistent. And in like 2021, during COVID, the group of Colombel reported on the alpha V beta 6 integrins. So again, other autoantibodies. So all this plus the association, which is stronger again for colitis, with typically autoimmune diseases. And by autoimmune, I mean where there is a plasma cell producing autoantibodies. And then there is the genetic susceptibility, which is in UC, particularly located to the MHC, so where the complex that makes possible the activation of B cells in response. So all this to say that B cells might have a role. But the problem is that we tried to inhibit B cells, and that was done in 2011 in the UK, and with rituximab, which is an anti-CD20, and it didn't work. It failed completely, no efficacy at all. Plus, rituximab is not a handy drug, so it was completely discontinued. But there is a reason, perhaps, why this didn't work, and this has been shown again by the group by Colombel, showing that while rituximab does its role and wipes out the CD20 are the vast majority, but not all of the B cells that we have. We keep on having, especially in the colon, CD19 cells, which are called plasmablasts and are precursors of CD20. So they stay in the tissue and they survive rituximab, and that this was step number one. The step number two was that they observed that in active UC and especially in refractory UC, this plasmablast, the CD19 positive cells are particularly dysregulated and alterated. So then the following thing was, and this is again copied by other immune-mediated diseases, they found out that if you wipe out all the B cell lineages, starting from the CD19, so the precursors, you get very good results in diseases which are otherwise considered to be completely refractory, so like systemic lupus or myositis. And this can be achieved not by an antibody, because the antibody doesn't penetrate the tissue very well, by other cells. So if you're not familiar with CAR T cells, these are T cells with a chimeric antigen receptor, which means that the cell itself was genetically engineered to target a specific antigen and to be activated without need for the co-stimulation. So it's ready, it's primed to go. So they live longer and they can penetrate the tissue and they can deplete all the B cells, in this case, the CD19. So this gets us to that very special case report that appeared in the New England Journal of Medicine in September last year of a patient who was a 21-year-old female who was refractory to every medication available for UC, all of them, and declined colectomy. So the girl happened to be in Erlangen in Germany, where CAR T cells are mainly studied, and they decided to try the B cell depletion line. So they first used blitonomab, which is it's a B cell engager, so it's not a CAR T cell, it's a monoclonal antibody, but depletes a B cell, and the patient had response, but then a relapse. So that kind of supported the idea that maybe they could achieve something with a deep B cell depletion, not rituximab-like. So then they went on. The CAR T cells are extremely expensive because you need to extract them from the patient, and that's the easy part. It's apheresis, and then you have to engineer them. So you have to design the gene specifically for that patient, expand them, extremely expensive and not so high yield because it's not easy, and then reinfuse them. And all this has to be done while the patient is completely depleted of the immune system. So has to be admitted in a hospital in an hematology ward with high risk of infection. But after the infusion, the patient went in complete remission, and up to 6 months, I think is the data line, she is drug-free, she's in remission without any drug. So potentially that was the first case of ulcerative colitis was cured, which is otherwise something that we all know it's not possible and has sparked a lot of interest. Now there are in fact 3 clinical trials that started. We're participating in 2 of this, and all of 3 include ulcerative colitis, and one of this also has the Crohn's disease arm, all targeting CD19, so the plasmablast, the precursors of the B cells. And it's obviously very early to say if we're about to look at a big change, a big shift in the paradigm, but this could be the ultimate solution for the cases that we don't know how to manage otherwise. And I think this was the last slide, so thank you very much.
¿Alguna pregunta de la audiencia? No, acá no hay nada. Bueno, ¿cómo ves el rol de los nuevos medicamentos, digamos, aplicado a escenarios de acceso diferido, digamos, como es en Latinoamérica? Cuando hablabas previamente en la primera charla de Difficult to Treat, una de las cosas que por ahí tenemos en algunos sectores es que el acceso, digamos, no es completo en todos los medicamentos en muchas regiones y probablemente sería mucho mayor el Difficult to Treat en nuestro escenario si tuviéramos más acceso, porque eso se vería de esta forma. Entonces, digamos, ¿cómo piensas que esto va a poderse aplicar en escenarios como Latinoamérica, sobre todo esto final?
Yeah, we have similar problems. We're not so different. So the access is always an issue. I think there is a lot of room for optimism because as the prices of older medications decline, it's true that you're going to have problems with the newer ones. But when biosimilars arrive, the prices drop a lot. And now, I don't think you have biosimilar. You said you don't have biosimilars of ustekinumab, but the day it's going to arrive, that will mean that at least ustekinumab will be very available. And it's true that we would like to have more access to the IL-23 selectives, but so there is a lag, but I think that the trend is still very, very good. On the other side of the newer medications that we mentioned, the only one that I think has a true potential to be a game changer for the very difficult patients is TL1As, which is again probably going to be expensive. The oral medications so far, I'm not, this is personal opinion, convinced that they are going to be as effective in the very refractory patients. So perhaps you're missing out more on the practicality of having a pill instead of an injection, which is obviously convenient, but less on the precious resource that you want to have for somebody that has failed everything.
Acá tenemos una pregunta acerca de la seguridad en terapias duales, cuando se hace combinación de tratamientos avanzados.
Yeah, so because we have so little evidence of how to choose, safety is the logical, safety and cost are the logical 2 other things that you're going to look at. So what we do in our practice, for example, is that when we want to use a combination therapy, the factors that we consider are safety. So usually we're pretty good with it, but if a patient was very, very old or with plenty of comorbidities, then I would be a little bit more cautious and I would choose like towards IL-23 and vedolizumab, for example, and try to avoid anti-TNFs. The other thing is cost. So because that is an issue, we tend to try to use things that have at least one of the 2 as a biosimilar so that the cost is almost 0. And the other thing and then of course the other point is what has the patient failed before? So if the patient failed anti-TNF and vedolizumab, I'm not going to propose the combination with another anti-TNF and vedolizumab. I'll try to swap around to another class. Safety is one of the key points, but honestly, never seen any problem I think we have 45 combination patients around that. No problems whatsoever so far.
¿Alguna pregunta por acá?
¿Una pregunta
No.
más?
Y nos queda la última, que es, nos preguntan de lo que era enfermedad perianal que había quedado, de experiencia con cámara hiperbárica.
No tengo.
No sé, no tienes.
No.
Bueno.
Una pregunta, hace un rato hablabas de las distintas formas de presentación, tal vez de la enfermedad de Crohn, y que tal vez estamos llamando de enfermedad de Crohn a muchos fenotipos distintos. ¿Hay alguna evidencia de algún tratamiento específico para cada una de las distintas presentaciones de enfermedad de Crohn? ¿Alguna preferencia que tengas vos según si afecta intestino delgado o colon?
The only thing I will say is that I use Vedo more on the colon than on the ileum. And in general speaking, and there is data for that, ileum tends to respond worse. So my reasoning is that I think of the ileum as a little bit more harder to treat. So if I'm in doubt, I use what I perceive to be as a stronger medication, although obviously we don't have clear evidence for that, for the ileum rather than the colon. That's, yeah.
Perfecto.
Bueno. Sí, una pregunta más. Sí.
De los marcadores que tenemos cuando queremos hacer posicionamiento. Así como surgió este HLA que hace que no responda al infliximab, o sea, ¿hay alguna otra perspectiva de marcadores biológicos o marcadores que digan por ahí ir para uno o para otro lado del tratamiento?
See, I think this is the key question everybody asks. So it's been very frustrating. And at last echo, there were 3 big trials. Profile is one, with all negative, all presentations negative. And the only ones that they claim they have a positive results, which is the GUIDE IBD study, the German one. I think it's in the selection of the patients and in the optimization. So I'm kind of cautious about that. But there is one good example of the contrary, which is in anti-TL1A. There is the study that came out on the New England, which showed that they had a panel of genes which they don't disclose. It's proprietary, so we don't know what's in there. that they claim, well, not they claim, they published that was able to identify the responders and increase the share, but most of all, decrease the non-responders to, I think, like 1 or 2%, like very, very low. So that would be the first example of something that really helps us decide whether that medication is good for that patient. Other than that, I'm not aware of anything that has worked. The other thing I will say is that the Omicron trial, which is ongoing now, and it's led by Amsterdam, and we're collaborating as well, which looks at epigenetic. So not the genes, but how they are modified later on. And it only looks at ustekinumab versus vedolizumab. So it's allocating one patient to one group or another compared to the physician decision, which is a random choice. So the preliminary hints that I got from a meeting were potentially good. There is no data yet out, but it's potentially good, and they validated this on retrospective cohorts. So there is a little bit of basis to believe that epigenetic could be one of the ways of looking at it. But it's for the moment, it's very speculation.
Una pregunta. La enfermedad inflamatoria intestinal aún no tiene cura, pero la gente tiene vida más larga. Por lo tanto, tenemos gente que tiene buena respuesta, pero se hacen añosos. Pasan los años, es otro escenario. En este caso, el step down de biológicos, o especialmente si usamos biológicos con riesgo, como anti-TNF, ¿se sugiere hacer un step down o un cambio de biológicos en pacientes añosos que responden favorablemente?
So, change of biologic, I would never change a biologic that was working, like never. Because you don't want to risk, especially in an old patient, to having to find out that, and then you cannot go back because it was infliximab. Oops. So no, I would not do that. Also, I would not stop. Whenever the patient asks, and they do ask a lot, not the old ones. The old ones are the good ones with taking therapy. They're it's the young people that don't want to make decisions. They ask about discontinuation. I tell them like you have 3 out of 4 chance. If they are not in remission, I don't even discuss. If they are in full remission, which is very few. I mean, it's very few patients that have absolutely zero evidence of disease. I still tell them that they have 3 out of 4 chances of suffering a relapse. And I would not advise running that risk because then we're probably gonna have lost one medication which was working. So again, I tell them like, why do you want to do it? Why is it bothering you so much to get an injection every now and then? If anything, I'm open to discuss, but I remember only doing it in one patient to increasing the length or the interval after testing the drug levels. That's one of the few cases in which I take for us it's very bothering to test drug levels because it takes a long time to get the results and the patient has to pay for it and so on. So it's one of the few cases in which if I see very high drug levels, the patient is doing extremely well. We're talking about anti-TNF because drug levels only work for those. Then we might consider instead of like doing every 2 weeks adalimumab, like moving to every 4 weeks. But that's the maximum I would go.
Una pregunta acá.
Recién dijiste que te sentías más cómodo usando vedolizumab en Crohn de colon que en intestino delgado. Quería saber si para UPA y para RISA consideras algo similar o...
So my personal, again, we're talking about personal impressions, is that RISA works, and we've used a lot of it, works extremely well for Crohn's, less so for colitis.
Yes.
And I believe that's the reason perhaps why Johnson & Johnson is running the study called CHARGE, which is guselkumab versus RISA in UC, because I think they spotted an area to show superiority. So RISA, great drug for Crohn's, still good drug for colitis, of course, but perhaps within the IL-23 class, not the best. And UPA, the opposite. I have the feeling, and actually this is supported by the Bent analysis and even the American guidelines, which they have this weird way of suggesting the level of efficacy, which we can argue about. But they tell you that UPA is a very good drug for colitis and less so for Crohn's. Now, there might be still niche areas in Crohn's where you want to use UPA. And I'll tell you that we're running with the JETED, the study of UPA in symptomatic strictures, just like the Creole study back in 2018 was showing that adalimumab can be helpful in some strictures which have a lot of inflammation to decrease a little bit the edema and allow the passage. So that is one of those settings where UPA might be a good drug. And again, UPA works relatively well in perianal disease if you take all the consideration. So more mixed feelings about UPA in Crohn's, like specific settings very good and maybe not the best for the traditional Crohn's.
Perfecto.
The study came out like maybe last year, at the end of last year, and it's, as far as I know, the only study of Crohn's disease like of the pouch. It's, as far as I know, it's the only one that tested, and I would treat it as a particularly aggressive Crohn's. That's my idea is that I would treat it as I would treat a particularly aggressive Crohn's. I would not treat it as a pouchitis, or I would more consider, for example, vedolizumab, which is the only one that has good data, like the Ernest trial. But it's a very niche setting, like very, very limited. And perhaps it's a patient that has already failed many drugs, because if he has a pouch, it's probably down the line.
Bueno, vuelta.
Entiendo que el futuro de los pacientes está absolutamente ligado a la regulación inmune pero me gustaría saber tu opinión sobre la optimización nutricional en los pacientes no respondedores.
See, so the non-response, there is a group of patients that non-respond because of they have low albumin. So those patients are the patients where nutrition can play a big role, like a concrete one, and you boost the albumin level, you boost nutritional status, and then you get a better result with the medication. So point number one. Point number two is the data coming from the bioptic study, so the Scotland one that presented at ECHO, where it seems like that partial enteral nutrition, so modulen, reduces the chances of developing anti-drug antibodies, which then means more efficacy for your drug. So again, very preliminary, very small numbers, and they are testing ADA and not infliximab, where anti-drug antibodies are arguably less of a problem. And other than that, I think I'm not aware of any other data about nutrition and modulation of the immune system, convincing data in IBD, but I might be wrong, of course.
Bueno, vamos a agradecer bueno, a Johnson Johnson, a Tomaso por todas estas hermosas exposiciones. Creo que hemos pasado por todo lo que son conceptos nuevos en desarrollo y el futuro de la enfermedad inflamatoria en lo que va a ser el tratamiento, en esta linda discusión. Y bueno, queremos agradecerte por haber participado en esto, que ha sido muy fructífero, a Johnson Johnson por organizarlo junto con Gadecu, esta actividad. Y que escaneen el QR, calculo que es para ver si la satisfacción, digamos, del evento ha sido de acuerdo a lo que esperaban, ¿no? Así que agradezco a todos y bueno, los invitamos a seguir charlando después, posteriormente, aquí un momento más. Muchas gracias.
Gracias.